Hello there. Evening, or somewhere in Eastern North. Good morning, good afternoon, whatever the case may be. We have hundreds of people logged in from around the world, and I'd like to welcome you all to this evening's, or this afternoon's, or this morning's webinar. My name is David Eisen. I'm a dentist. I practice in Toronto. I have a sedation-based dental practice, and I do a little bit of lecturing on the side about topics related to medical emergencies and local anesthesia as well. I'd like to thank Purell Pharma for sponsoring this lecture. They have over 30 years of experience in the dental anesthetic marketplace, manufacturing their local anesthetics internationally. So thanks to Purell Pharma for sponsoring this talk. As well, I'd like to thank Viva Learning for being the portal for this lecture and allowing us to share information together in such an easy way. So for the next 50 minutes or so, I'm going to do a brief presentation about local anesthesia-related emergencies in the dental office, something that we all are in danger of having happen to us in our practice if we are using local anesthetics. And there are a lot of people logged on this evening, and I think that attests to the importance of this topic. So the three topics that we're going to cover this evening are one, toxicity, of course, which is an important local anesthetic emergency that we all need to have in our minds as we practice dentistry and inject local anesthetics. We're going to look at seizure disorders, not only as they relate to local anesthetic injections, but also just as an emergency itself, as seizures can happen in a dental office for a number of different reasons, not only for local anesthetic overdose. And we're going to look at allergy, and we are going to see which types of things in the dental office can cause an allergic reaction, and understand the differences between mild type allergies and life-threatening allergies like anaphylaxis. And also, we'll take a look at some of the things we need to do to manage these issues. If we think about toxicity as our first topic, and think about topical anesthetics, who would think a topical anesthetic could cause a toxic reaction? Well, really anything that is ingested into the body or the body is exposed to in huge amounts can lead to toxicity. Even water, where we drink too much, huge amounts, there have been cases of people dying of water toxicity. Now with topical anesthetics, we're not going to get a toxic reaction when we use a small little dab to get soft tissue anesthesia for a needle puncture. But if we use the drug incorrectly, as in the case of a few FDA reports where people slather large amounts of topical anesthetic, for example, on their legs before laser hair removal, and huge amounts of local anesthesia is absorbed through the dermis, certainly that is a risky way to use a topical anesthetic. Now, we're not doing these risky things in dentistry, but the message here, I think, should be that topical anesthetics are absorbed. And if you are using, let's say, an amide-based topical anesthetic, that would be maybe one that has lidocaine or pilocaine in it. That amide will be absorbed, a small amount, of course. But if we have a very small patient, and or if we have somebody who is quite sensitive to the toxic effects of local anesthesia, and we'll talk about who those people are and how to recognize that, well, maybe a topical anesthetic needs to be accounted for while we're doing our injections. So how do we know how much local anesthetic we can give to our patients? What is a safe amount? What are the numbers that we should have in our head? Whenever I ask this question in my lectures, few people are able to right away yell out a certain number in milligrams per kilogram or a maximum recommended dose of a specific local anesthetic. Very few of us have these numbers in the forefront of our minds, probably because local anesthetics are very, very safe drugs. However, as we are using these drugs, I think it's our responsibility to know what the maximum doses are, and we can now calculate the correct volumes to give, especially to our smaller patients. So all of our local anesthetics come as a percent solution. What does that mean? Well, we have to change the percent to milligrams per mil in order to be able to calculate how much drug is in a cartridge. So for example, if we think about how much volume is in the cartridge first, think about, well, depending on where you practice, different parts of the world, we need to consider different volumes. So if you're in the UK, you have 2.2 mils in your cartridge. Here in North America, we have about 1.8. Now there was a study done where they measured the actual average volume of a local anesthetic cartridge in North America, and the actual real average volume, articaine and lidocaine, turned out to be about 1.76. So because we're never getting 1.8 mils, we have to, the local anesthetic companies are only allowed to advertise 1.7 mils because we're never getting 1.8. The cartridge itself in North America holds 2 mils, but we have to make room for the stopper, and that takes up 0.2. So we're left with this strange 1.7, 1.8 number. Now for safety, as we calculate our dosages, we'll err on the side of caution and use 1.8 mils as our calculator instead of 1.7. So here's how we change the percent solution to milligrams per mil. We first realize that 2% means 2 grams in 100 mils of liquid. 3%, 3 grams in 100 mils, 4%, 4 grams in 100 mils of liquid. 2 grams is equivalent to 2,000 milligrams. So 2,000 milligrams in 100 mils of liquid, or if we get down to almost cartridge size, 20 milligrams in 1 mil. So every mil of a 2% solution has 20 milligrams of drug. Now if we multiply that v milligrams times the actual volume of the cartridge, 1.8 mils, we calculate that one cartridge of a 2% solution has 36 milligrams of drug. So one 2% lidocaine cartridge has 36 milligrams of drug. Now that doesn't mean anything if we don't know what the maximum dosages are. We need to know the maximum recommended dose and, again, more importantly, the milligram per kilogram dose that we're allowed to administer. The maximum recommended dose of our 5 amide local anesthetics are seen here on this chart. And generally, we should always consider that if we take the vasoconstrictor out of the local anesthetic cartridge, the local anesthetic is more available to the cardiovascular system. That means it's more toxic. So without epinephrine, there's no vasoconstrictor, so we get some vasodilation in the area because local anesthetics are actually vasodilators. So the local anesthetic without a vasoconstrictor is more available to the cardiovascular system. That's why in the dental industry in North America, articaine and lidocaine don't come as plain solutions. If we were to inject a plain solution of articaine and lidocaine, we would have a very short duration of anesthesia because of the rapid uptake of the local anesthetic into the cardiovascular system due to the vasodilatory properties of articaine and lidocaine. Mepivacaine and pilocaine are not as potent a vasodilator, and so they do work as a plain solution. However, with mepivacaine, we have to put more drug in the cartridge to make it work as a plain solution. We'll look at that on the next slide. So these maximum recommended dosages are for only an average, healthy, 70 kilogram adult. That's the only patient that these numbers apply to. So we have to adjust the dose for age and for weight. As we age, there are reasons why we should be administered less anesthesia. We'll look at that in a few minutes. So here's something called the toxicity dose-response curve. And this dose-response curve applies to pretty much any drug. Let's look at alcohol, for example. There are some people who can drink one beer or have one glass of wine and feel kind of drunk. Those people have a low tolerance, and they will be on the red or left side of this graph. Some people can drink 4 beers or 5 beers or drink a full bottle of wine and feel no symptoms of being drunk. Those people obviously have a tolerance. They're on the other side of the graph. And these people, they're sort of aberrant with respect to the way they react to alcohol or a drug. They're not average. They either can't take very much or they can take a whole lot. But of course, most people would be under the toxic dose average green sort of middle area, where the normal amounts will elicit the normal toxicity responses. An example of a low dose local anesthetic toxic patient responder would be someone who starts to yawn after 2 cartridges of a 4% local anesthetic, or after an inadvertent intravascular injection of local anesthetic, someone starts to tell you they don't feel well. They may be exhibiting a toxic reaction to a bolus of local anesthetic intravascularly because they're more sensitive to the effects of the drug. So we'll look at the signs and symptoms of local anesthetic toxicity so that we're 100% crystal clear what the toxic response looks like, so we can identify those low tolerance individuals. So this is the important graph or chart with respect to the maximum dosages of local anesthetic, because this is what applies to everybody. We can use the milligram per kilogram value and calculate the amount of local anesthetic that any patient can have based on their kilogram weight. And we'll look at some examples, especially for small children, in a few slides. If you look at articaine and lidocaine, they have the same maximum milligram per kilogram dose. It's 7, both of those local anesthetics. That doesn't mean you can give the same amount of both, because they may not be the same percent solution. Now, in North America and in many other countries, articaine is a 4% solution. Lidocaine is a 2% solution. Well, if articaine is 4%, that means it has twice as much concentration, twice as many molecules of drug in the cartridge compared to 2% lidocaine. That means you can only give half as much volume, even though the milligram per kilogram dose is the same. So on the right side of the chart, you see articaine, the maximum number of North American 1.8 mil cartridges is 7 cartridges, and lidocaine, you can give about twice as many cartridges, about 13. With mepivacaine, I said as a plain solution, you have to put more local anesthetic in the cartridge. So mepivacaine plain is a 3% solution in North America. With a vasoconstrictor, it's 2%. As a 2% solution, you can give 11 cartridges of mepivacaine. But take the vasoconstrictor out, because it's now a 3% solution, you can only give 7 cartridges of mepivacaine. 3% plain solution for the average healthy 70 kilogram adult with this milligram per kilogram calculation. Patient factors with respect to toxicity are, of course, age, because younger people are smaller. Older people may have decreased liver function. And with decreased liver function, people may be more sensitive to the toxicity of local anesthetic. So for people who are older than 60 or 65, we should start to dose them down a little bit and not reach our maximum amounts, just to make sure that their liver can manage the volume that we're injecting. Now with articaine, this is a drug that's metabolized more in blood by an enzyme than in the liver, like our other local anesthetics. So maybe for older individuals or for people with liver issues like hepatitis or alcoholic liver disease, articaine is a good local anesthetic because they may be able to metabolize this local anesthetic better. But don't forget, at least in North America, it's a 4% solution, and so we can only give half the volume, regardless of the patient's ability to metabolize the drug. Also, from the perspective of cardiovascular health, and we talked about this in detail in our last webinar when we discussed vasoconstrictors in dentistry, people with compromised cardiac systems, we need to be careful with the vasoconstrictor. And there's always a hand-in-hand relationship between cardiovascular wellness and dental anxiety, and the challenge of giving good local anesthesia and making sure people are numb throughout the course of the procedure so that we're not causing more stress and anxiety, increasing the risk that patient is going to have a medical emergency, and being numb is the most important thing. Clinically, the factors that relate to local anesthetic toxicity are, of course, giving too much drug, injecting too much of it too quickly, by mistake injecting into a vessel, and we'll look at how to avoid that in just a moment. Intraosseous injections happen to be quite toxic in their in the fact that the local anesthetic is absorbed very quickly into the cardiovascular system in the cancellous bony area. It's a very vascular location, and so we should really minimize our concentration of injection for intraosseous procedures, and the vasoconstrictor is especially of consideration for intraosseous injections. And again, if we use no vasoconstrictor, once again, local anesthetic is more available to the cardiovascular system. And really, we're quite complacent with our local anesthetics because they are so safe. And having medical emergency related to the injection of a local anesthetic is quite rare. So we become comfortable and maybe don't always think about toxicity on a day-to-day basis. Should an overdose of local anesthetic occur, the reaction will happen in about 5 to 40 minutes after the injection has happened. Be especially careful in our patients, especially children, who are taking central nervous system depressants, people who are on sedatives or maybe have a narcotic patch for pain, and any drug that could interact with the sedative effect of the local anesthetic could potentiate the toxic reaction. Now, how do we know for sure if we are aspirating correctly? Of course, some of our injections, the tissue is more vascular than others. The pterygoid plexus location, the maxilla, posterior to the upper second molar and third molar area, there's a plexus of veins there, so this is a very vascular location. The pterygomandibular triangle is also a very vascular location, and these are locations where we especially want to be sure we're not in a vessel before we inject. Some syringes may aspirate more efficiently than others. With a self-aspirating syringe, if the syringe is in good working order, we should have the syringe do what it needs to do. But a manual syringe needs to be set up in the correct order for it to be able to aspirate correctly. With a manual aspirating syringe, this is the syringe where we actually have to pull the thumb ring backwards to get back pressure for blood to be sucked into the local anesthetic cartridge. We have to embed the harpoon of the syringe into the stopper of the local anesthetic cartridge. Then, once that's done, we screw the needle onto the syringe as a last step. If we screw the needle on first and then try to engage the harpoon of the local anesthetic syringe with the local anesthetic cartridge stopper, we won't get a connection because the stopper will move as the syringe will inject anesthetic. So the needle should be screwed on as a last step after the harpoon has been engaged with the local anesthetic stopper. Gauge of the needle is a factor. 30 gauge needles, which many of us use for all of our injections, are not reliable aspirating needles. Many of us use them because we think maybe they hurt less, but that isn't what studies show. Studies show patients can't tell the difference between the pinch of different gauge needles, whether it's 25, 27, or 30. And so really 30 gauge needles don't do a whole lot for us with respect to the patient's perception. Now, of course, with a larger gauge, the local anesthetic has the potential to flow out faster because of less resistance, and that could hurt more. It's the tissue expansion that obviously is what hurts when we inject, and so we have to be quite mindful to do slow injections. Now, with needle gauge, whenever we're injecting into a vascular area, we should make sure we're using a 25 gauge needle to give us every possible possibility of realizing a positive aspiration when we use the syringe to create the aspiration. Especially for people with liver disease, pregnant people, cardiovascular patients, we want to make sure we're not doing a bolus of local anesthetic directly into a vessel. So what does a local anesthetic toxic reaction look like? Local anesthetic toxicity reacts both on the cardiovascular system and on the central nervous system. And sometimes you will see a gradation of effect from mild to moderate to severe. It's not always the case. Sometimes we just get the severe, sometimes we just get the moderate, but most often in most local anesthetic toxic reactions, we'll just see the mild response. And this has probably happened to many of you, and you haven't realized it's occurred, maybe because the patient hasn't told you they're not feeling quite right, or they have told you and you haven't chalked it up to local anesthetic toxicity. So restlessness, confusion, slurred speech, blurred vision, metallic taste, flushed, chilled, feeling nausea, headache. These are signs of a mild local anesthetic toxicity. And by the way, the local anesthetic will be metabolized, obviously, and that mild response should go away if we haven't given too much or if the patient isn't too sensitive to the toxic effects of the drug. The more moderate signs and symptoms of local anesthetic toxicity are where we get an increase in blood pressure, an increase in heart rate, an increase in respiratory rate. This could lead to a seizure, and this could lead to unconsciousness. And now we have a problem, and we should be calling paramedics into our office as fast as possible. The severe signs and symptoms are quite scary, where the CNS becomes depressed, sedation occurs, blood pressure, heart rate, respiratory rate, these things depress, and this could eventually lead to a coma. Now, again, the sedation could happen sooner rather than later. So we could see the sedation and the drop in vital signs or at the beginning of the response, not necessarily after the mild and moderate have occurred first. With children, unfortunately, it happens, I would say, every year where a child dies from a local anesthetic overdose. It's not unheard of. And it really doesn't have to happen. And we have to be aware of the signs and make sure we're not making things worse when the early signs appear. The most common local anesthetic used in pediatric deaths is 3% Notificaine without a vasoconstrictor. I'm not sure why that is, but a few guesses might be because dentists tend to use this more on children because they're trying to reduce the duration of soft tissue anesthesia, so maybe the child won't bite their lip. But really, if you look at the duration of anesthesia charts, there isn't a significant difference in duration of soft tissue anesthesia, so it doesn't really help us to use the plain solution. And there's a mistaken belief that without the vasoconstrictor, the local anesthetic is less toxic or more gentle, when in fact the opposite is true. The other bad scenario is that when a child falls asleep in the dental office, the dentist or the operator misinterprets that toxic response for cooperation and continues on with treatment, maybe even gives more local anesthetic, and doesn't manage the airway and maybe doesn't call for the paramedics. So here are some volumes to consider if we're treating a small child, a 15-kilogram child. Let's take about 30 pounds for our U.S. friends. If you take a look at the volume of local anesthetic, the number of cartridges you can give to this very small child, you'll see you can't give very much. With 2% lidocaine, we can give under 3 cartridges. With 4% articaine on the bottom, we can give half the amount. Again, it's twice as concentrated, the same maximum dosage for toxicity, so we can give less than 1.5 cartridges for a 15-kilogram child. With the 3% mepivacaine, the plain mepivacaine, we can give less than 2 cartridges. So you can see a very small volume is allowed for our smaller patients. And if you look at this chart, you might think, why would we ever use a local anesthetic on a small child that gives us less of a safety window? And what happens if that 15-kilogram child also happens to be the child who is more sensitive to the effects of the local anesthetic? The scenario that causes these catastrophes is a child who let you do multiple injections, the pressure that we have to maximize our productivity, our complacency again, the fact that these are generally safe drugs, the misinterpretation, sedation is cooperation, and the unlucky scenario where the child is more sensitive to the local anesthetic. The safest anesthetic for a small child is one with a vasoconstrictor and the smallest percent solution that you can find in your armamentarium, and that in North America would be a 2% solution. If you do have a local anesthetic toxic reaction, here's the algorithm that you might proceed through in order to help the patient. With the mild response on your left, we go through an acronym in any emergency. The acronym is P, CAB, and then D. P means position. With a mild emergency, the patient is conscious, so we want to make their position to be one of comfort, so whatever makes them comfortable. And then the CABs, the circulation, airway, and breathing. You can skip this because they're breathing. You can just look at them and tell that we don't have to do anything. And then we go right to D, make a diagnosis, and decide, does the patient need a defibrillation or do they need a drug? And in this case, they need a drug, which would be oxygen. And we just let them recover. And then if you have good local anesthesia and the vital signs are stable, you could even carry on with the dental procedure if the patient is feeling well enough. If not, allow them to go home and come back another day. With the severe response, as soon as you suspect severe local anesthetic toxicity, call for the paramedics. P position would be to put the patient supine with feet gently elevated. Airway, airway, airway. Make sure you do a head tilt, chin lift to open up the airway, just to make sure the patient is able to breathe. Give oxygen, and if they're not breathing, it has to be positive pressure oxygen. And that's something that you should know how to do through a good medical emergency course. If the patient is seizing and you are comfortable and you have a benzodiazepine in your practice, you could administer a benzodiazepine like Dazolam into a muscle. That's more advanced care, and I think that as a general dentist, the most important thing should be for us to protect the patient and manage their airway and make sure the paramedics are on their way. Another type of local anesthetic toxicity specific to certain local anesthetics is called methemoglobinemia. This is a toxic-like response from usually prilocaine. Prilocaine is the most common local anesthetic associated with this emergency. Methemoglobinemia is an emergency where the hemoglobin cannot carry oxygen. They become denatured such that the iron atom gets an extra positive charge. Normally in our bloods, we have about 1% of our blood methemoglobin, and we live with that, and it doesn't make us hypoxic. But if we have too many of those methemoglobin cells in our blood will not be able to carry sufficient oxygen and will become hypoxic. Some people have this disorder congenitally. They have an enzyme deficiency. These people have blue tinge to their skin because their blood is a brownish color. There are stories of these blue families because this is a genetic disorder. From an acquired perspective, in dentistry, the real important culprit is prilocaine, because too much prilocaine, when it's metabolized, one of the metabolites of prilocaine can cause methemoglobinemia. There are cases in medicine, in operating room situations, where articaine and benzocaine have caused methemoglobinemia. Never in dentistry. With benzocaine, it's large amounts of topical anesthetic sprayed into the oral pharynx before intubation. The tissues maybe get abraded. Large amounts of benzocaine are absorbed. That has caused hemoglobinemia. Sulfonamides and pathway antibiotics also have been shown to cause this emergency. The emergency happens about 2 hours after treatment in the dental office, and so typically a patient will call back the dentist and say that their child is blue. Their fingernails are blue, their lips are blue, and they're out of breath. They can't catch their breath. They feel as though they're always out of breath. Giving oxygen will not help because the blood has too much methemoglobin. There is an emergency drug that these patients have to receive called methylene blue, and that is given in the operating room. So we have to get these people to the emergency room. You have to go to the hospital as fast as possible. Now, what about seizures? Seizure, we talked about a seizure being one sign of local anesthetic toxicity. What other medical issues can cause a seizure? Well, of course, we all know epilepsy is a seizure disorder, and people who have epilepsy will have seizures. We'll look at the types of seizures that you see. Hypoxia, syncope. If somebody has a syncope reaction, one of the signs of syncope is a seizure. That's not uncommon. Hypoglycemia also. People can have seizures if they're too hypoglycemic. Of course, alcohol withdrawal, anaphylaxis, fever infection, and even during a stroke, people may have seizure. So the classification of seizures in epilepsy, there are 4 types of seizures that are classified. The first, petit mal or absence, where you might see a blank stare. And all of these, by the way, are a loss of consciousness. So while the seizure is happening, even if it's just a blank stare, the patient won't know it's going on until they wake up, and then they know they've had it. So these people really, for all intents and purposes, are unconscious. A myoclonic seizure is one where there's repetitive muscle jerking, like an arm twitch or a leg twitch. An atonic seizure is one where people lose complete postural tone and they fall to the floor. And then the seizure we all know and have heard of, a grand mal seizure, most common, it makes up almost 90% of seizures. This is the one where the whole body will twitch and writhe, and we have to protect the patient from injuring themselves, especially their head, while the seizure is happening. Seizure progression is such that people usually will have it, or people usually say that they know the seizure is going to occur before it happens. And they'll tell you. Your patients with seizures might warn you that they're about to have a seizure. Then the ictal phase is the loss of consciousness and the seizure itself. And the post-ictal stage is where they regain consciousness and they have an altered mental status. So they really don't know what's going on. It may take them some time to remember where they are or what's happened. And the patients tell you that certain things cause an aura, like a bright light or a vibration. I have a patient who has a seizure from the vibration of the dental chair going backwards. So we have to put the dental chair into the right position and allow her to get into it. So we just have to know what provokes the seizure and obviously avoid it. To manage a seizure, so the P, C, A, B's, and D's of managing a seizure emergency, the P would be to put the person supine if you could and protect their head, and then allow the seizure to occur and consider calling for paramedics. If the person has a known seizure disorder and they say to you, you know, I have seizures, they happen once or twice a month, they last 3 or 4 minutes, and this is what's going to happen, and that's going to happen, and then I'll come to you and I'll be okay. You don't have to call EMS or paramedics because this person knows what's going on and they live with their disorder, and that's okay. If it lasts longer than 5 minutes, and or if it's different than what the patient tells you it usually is, then I think we should consider calling for a paramedic. A seizure might be the only emergency in the dental office where I would consider allowing a family member into the operatory to help me, because family members are used to managing their family who have seizures in front of them, and they generally know what to do and can be quite reassuring while the seizure is happening. And then we go to the CAB to make sure that their airway is open during the seizure. Head tilt, chin lift. We should give oxygen. And again, consider if we're qualified and we understand the use of a benzodiazepine to help control the seizure. But remember, benzodiazepines in general aren't very good when we inject them into a muscle. They work much more effectively intravenously, and if we don't have an intravenous line in place and we're not used to picking one up, getting one on somebody with a seizure, again, if you're not used to it, might be tricky. So I'll just skip this algorithm because I pretty much said everything that's in it in the last slide. Let's take a look at allergy. Think in your head as we go through this last slide series, what is it that causes local anesthetics to create an allergic reaction? Do you think it's a local anesthetic? Is it some other factor in the cartridge? Are topicals as allergenic as injectables? First of all, when we do our medical history questionnaire with our patients, it's important to distinguish between what an allergic reaction is and what a side effect is. It's common for patients to misinterpret a side effect as an allergy. Common reports to dentists are, yeah, I had an injection of local anesthetic, and my heart raced, and I got a headache, and I'm allergic to epinephrine, which of course is impossible. If you'd be allergic to epinephrine, you'd be dead. Another common report we hear from our patients is, I can't have codeine, it makes me constipated. Well, of course, constipation and heart racing from epinephrine are side effects of drugs. They're not allergies, and they're not reasons not to use those drugs. You have to use them maybe a bit more carefully if there are side effects present, but they aren't omissions for the use of those drugs. The signs and symptoms of an allergy, of course, are hives, swelling, rash, itchy, runny nose, runny eyes. We'll look at the specific symptoms in a moment. So we rule out side effect, we rule out syncope if that's what happened to the patient, and if we think the patient really truly had an allergic reaction after they were exposed to something in the dental office, well, now we have to do some detective work and figure out what it was. Does the patient know the drug they were injected with when they had that allergic reaction? Was it a specific local anesthetic? Was it a topical anesthetic? It's a good thing to do if we don't know, to refer the patient to an allergist and find out what the culprit might be. Now, with local anesthetics, amide injectables, the 5 injectable amides that we have in North America, are rarely allergenic. Much more commonly than the amides are the preservatives in the local anesthetic cartridge. So we'll look at those in just a moment. But if we think the preservative might be an allergen, when we send our patient for testing, we have to specify that we want preservatives tested for, those so-called sulfites that are in some of our local anesthetic cartridges. So common causes of anaphylaxis outside of the dental office are things like wasp stings, certain foods like peanuts, of course, milk, eggs, penicillin, medications, latex. We know these common precursors of anaphylaxis. In the hospital operating room, the list of culprits in anaphylaxis are interesting. Muscle paralytics made up the highest incidence of being associated with cause factors of anaphylaxis. Latex was second, and antibiotics, hypnotics, opioids, and other drugs. You don't see local anesthetics on this list, and of course they are used in hospital operating rooms. In our offices, of course, latex has to be considered as an allergen. And if we take a latex rubber dam off our patient's face and their whole face is red with rashes and hives, well, obviously they've had an allergic reaction to latex. The local anesthetics that we use in our office are either esters or amides. All of the injectables are amides. Our topicals are esters or amides. Now with amides, if you have an allergy to one amide, like lidocaine, it doesn't necessarily mean you have an allergy to another amide, like prilocaine. So we should get tested to find out if one of the amides is the issue. Another one of the amides may be okay for that patient. With esters, our topical anesthetics, like benzocaine and tetracaine, the culprit for allergies with esters is that a metabolite called PABA is present, and that is the allergen. So all esters break down to PABA. PABA is the allergen. So if you can't have one ester, you can't have any ester. You can't choose one that might not be allergenic. In some places in the world, in some of our multi-dose local anesthetic vials, methylparaben is added as a preservative. That also breaks down to PABA, and it could be an allergen. However, in North America, no dental cartridge has methylparaben anymore. Sodium metabisulfite, this is the preservative for the vasoconstrictor in the local anesthetic, also an allergen, and much more commonly an allergen than the amide local anesthetic itself. And we'll expand on the sulfite issue in just a second. Another interesting allergen I came across with a patient, she had an allergy, an anaphylactic allergy to gel foam in the hospital room, in the hospital operating room, because she had an allergy to pork products, and gel foam apparently has a porcine product inside of it. So we know that providing a latex-free environment for our patients is very difficult. Many things that we use in our practice will have latex inside of it. So if our patient has an anaphylactic reaction to latex or a severe latex allergy, we have to be very, very careful when we treat them. There is no issue with local anesthetics though. Local anesthetic cartridges do not have any latex in them anymore. They used to. Now the plunger and the diaphragm are non-latex. They're a rubber called bromobutyl, and you don't have to worry about that with respect to latex allergies. So what is this sulfite issue with respect to our local anesthetic cartridges? Sodium metabisulfite is added to our local anesthetic cartridges with a vasoconstrictor. So anytime your local anesthetic has a vasoconstrictor, like epinephrine or levonorepinephrine, it will have sodium metabisulfite. And that is added to the cartridge to preserve the vasoconstrictor from oxidation. It prolongs the shelf life of the cartridge. Now that being said, even though a cartridge with preservative has a prolonged shelf life compared to without the preservative, when you put the preservative in, the shelf life of the local anesthetic is shorter. So plain solutions do have longer shelf life. So a sulfite allergy or sensitivity is not the same as a sulfur sensitivity or a sulfa sensitivity or allergy. Sulfur is a element that obviously exists in our world. It's in our bodies. We can't be allergic to it because of the fact that it's inside of us. We can get a rash if we're exposed to sulfur somehow. It can give us a skin burn, but it's not an allergen that we need to be concerned about with respect to local anesthetics. A sulfa allergy is an allergy to a class of antibiotics, sulfonamides, different than a sulfite allergy. And a sulfite allergy is one that patients commonly know they have. They might tell you that they can't go to a salad bar, or they can't eat food that has a lot of preservatives. They can't eat nuts or dried meats or red wine or some fruit juices. There are a lot of products that we ingest that have sulfite preservatives in them. And people feel sick and they get rashes and common allergic reactions if they ingest or are exposed to these products with sulfites in them. Now, a sensitivity to sulfites in this way doesn't necessarily mean that a patient will have an allergic reaction if we inject them with a cardiolocal anesthetic that contains a vasoconstrictor. However, you should be cautious, and I think it's good practice if our patient has a sulfite sensitivity to use a plain local anesthetic to avoid exposing the patient to that drug. Local anesthetic product monographs say that if the patient has asthma or if they have an allergy, there's a higher risk of a sulfite allergy and being asthmatic correlating with each other. So asthmatics are more likely to be sulfite allergic, and people with sulfite allergies are more likely to be asthmatic. There seems to be a correlation. The signs and symptoms of mild allergy. So what's the difference between a mild allergy and a severe one? And when should we use Benadryl? When should we use epinephrine? Well, mild allergy, of course, are the signs and symptoms we're all familiar with. Itchy, red skin, blister, hives, rash, wheezing, shortness of breath, coughing, watering nose, watering eyes, nausea, vomiting, headache. Common signs of a mild allergy. By onset, the more delayed the allergy is, the less likely it is to be life-threatening. An allergy can take up to an hour to develop, and there are even rare cases of anaphylaxis happening 72 hours after an exposure to an allergen. Histamine is released in the body for up to 72 hours up after an allergy exposure. The immediate responses are the ones that are more scary. They involve the respiratory system and or the cardiovascular system, develop in seconds or minutes, and these can be life-threatening. I'll come back to this slide in the next few seconds. With anaphylaxis, this again is more commonly to happen sooner rather than later. The sooner it happens, the more likely it is to be fatal. 96% of anaphylactic fatalities happen within the first hour. But only 1% of anaphylactic reactions result in death. So most people will survive anaphylaxis, possibly because we know what to do generally, and most often we'll do the right thing. We need to have 2 doses of epinephrine in our medical emergency kit. Anaphylaxis can come back. It can recur. Epinephrine has a very short half-life, and when it wears off, it's possible that anaphylaxis will come back. And so after 10 minutes or so, we need to be very careful to see, are the signs and symptoms of anaphylaxis happening again when the epinephrine wears off. Anaphylaxis classically progresses from the skin to the eyes, nose, GI system, and then the respiratory system, and finally the cardiovascular system. By definition, either the respiratory system has to be compromised and or blood pressure has to drop severely or at all. If you see a drop in blood pressure, or wheezing and bronchospasm, that's called anaphylaxis. And that's when we get a the antihistamine that we have in our medical emergency kit, diphenhydramine is one example. We give this, again, for the mild allergy, and we give it for anaphylaxis after we've given epinephrine. So those are the two times that we would use diphenhydramine in our medical emergency kit. For this drug, the dose for an adult is 50 milligrams into a muscle, and for a child, it's about half that amount. The milligram per kilogram dose for a child for diphenhydramine is 1 milligram per kilogram. So remember, Benadryl or diphenhydramine or antihistamine is for the itching, hives, rash, and epinephrine is for the closing of the airways, the bronchospasm, and the severe drop in blood pressure that happens with anaphylaxis. Here's a vial of Benadryl. This is something that we need to know how to use. We all have these in our medical emergency kit. When have you ever used it? Practice using it. Every year you have to throw it out because it expires. So you buy your new one. Before you throw out your old one, make sure you know how to get the diphenhydramine out of the vial. You have to flick off the purple cap, and then you have to push in about 1 ml of air to get back pressure. Hold the vial upside down, make sure the needle is in liquid, and the back pressure will then allow you to draw the liquid out. It's tricky and not the easiest thing to do. We inject this drug into the deltoid muscle, which is 2 to 3 fingers below the point on the shoulder. So read up about how to do a deltoid injection. Make sure you're familiar with this maneuver. This is where we'll also inject a syringe of epinephrine. Same muscle. But with epinephrine, we should do an aspiration because we want to make sure we don't do intravascular injection of epinephrine. That could be too strong for the cardiovascular system. Benadryl, it doesn't matter. It can go intravenously. In fact, it's preferred if it goes intravenously. It'll work faster. So if you have the ampule of Benadryl, this is the ampule of epinephrine. This is what it looks like. It's a 1 in 1,000 solution. It has 1 ml or 1 milligram. And again, it's something that you should know how to use if you have it in your kit. So practice breaking the ampule. You know that it's scored at the neck. You could use gauze. There's a certain position for your thumb. Read up about how to crack an ampule and make sure you know how to get the solution out of there before the emergency happens. You don't want to be fumbling with this thing when your patient is dying from anaphylaxis. Now, auto-injectors are available to put in a medical emergency kit, and some would think that these are easier. But that's not always the case. It's very easy, and it commonly occurs that auto-injector can be used incorrectly. They have instructions on them. There are a few different types available in North America. I'll show you both. Just make sure that you always hold these in your fist and not put your thumb over one end in case they're administered upside down. You want the drug to go into your thumb instead of the patient's thigh. So these should be used in the thigh. You don't have to expose the skin so the pants can stay on, unlike the deltoid where the skin should be exposed. And we went and practiced doing a auto-injector injection. Again, you're throwing this out every year, so practice using this on an orange. This must be kept in the muscle for 10 seconds. One common mistake is to push it in quickly and remove it quickly. But we should count to 10 and make sure it stays in the muscle for 10 seconds. And we have to push. If we don't push, we may not be in the thigh muscle, vastus lateralis muscle. And then we'll do a subcutaneous injection, and it'll take 20 minutes for the epinephrine to get absorbed into the cardiovascular system. So if you do one of these auto-injector injections into the thigh, the two key points are push to make sure you're in the muscle and leave it in for 10 seconds. You can see here is an EpiPen, and it can be confusing which end the needle comes out of. The adage is orange to the thigh, blue to the sky. So, but you can see with the blue cap off on the right, it looks like a needle might come out of there, but that's not the needle end. The needle end is the orange end. So you can see why it's not uncommon that these are held upside down. EpiPen comes in 2 packs. So if this is what you want to put in your medical emergency kit, you can buy a 2-pack, and now you have your 2 doses in case you have a recurrence of anaphylaxis. The EpiPen Junior has half the dose. The EpiPen itself is 0.3 milligrams. EpiPen Junior is 0.15. And if you're using the ampule, you would again give either the 0.3 milligrams or 0.3 mils, it's the same thing, or 0.15 milligrams or 1.15 mils for the child. So know that, make sure you know what the dose is and how to calculate. These auto-injectors have been difficult to get in the US, and you can see they're about $100 each. And so if you're going to get 4 of these, let's say 2 for a child patient and 2 for an adult patient, you're into your medical emergency kit, $400, and that's why a lot of people carry one ampule and an auto-injector. Another example of an epinephrine auto-injector is Allerject in Canada, OVQ in the US. It's the exact same product. The device in blue is the pediatric device. Same dose, 0.15 milligrams of epinephrine. The orange dose, 0.3 milligrams for the adult. This is a nice device because it actually has a voice prompt. So when you take the lid off, it talks to you just like an AED. And it has a countdown. So when the device is injected into the muscle, it counts down quite loudly, 5, 4, 3, 2, 1, injection complete. And then you know to remove the device. So it removes a lot of error that might occur using an auto-injector. So here is the picture of the thigh muscle, the vastus lateralis. We're doing mid-thigh. Laterally, the needle should go in perpendicular to the skin. And again, the muscle might be quite deep depending on how much fat the patient has in their thigh. Even in children and infants, studies have shown that the thickness of the fat is thicker than the length of the needle of the auto-injector. So it's very important to push when we do this injection to ensure the drug deposited into the muscle. And whether you choose the ampule or the auto-injector is really whatever makes you comfortable. The disadvantages of having to calculate the dose, draw the drug, exist with the ampule, but the ampule is very inexpensive, has twice as long shelf life, and there are fewer risks of injury except maybe cutting your finger on the glass when you open the ampule. Whereas the auto-injector, it does have the issue of being used incorrectly sometimes. We have to make sure we push with this, and they're quite expensive. But we don't have to calculate the dose. Lastly, before I summarize, and then there'll be some opportunity for some questions, the anaphylaxis algorithm. So if you are unfortunate to have an anaphylactic reaction, or you witness one, whether it's in your office or in the real world, remember P, CABD. P, position the person comfortably, they're likely conscious. CABs you can skip because they're likely conscious and breathing. You can go right to D, call 911. That is, get the paramedics mobile as quickly as possible, give oxygen, give epinephrine, and after the epinephrine, then give the antihistamine. And remember the dosages, take a good medical emergency course, make sure you're familiar with dosages for the pediatric and adult population. To summarize, local anesthetics are generally safe. Emergencies are rare, but they happen. We can minimize the risk of emergency by knowing the patient's medical history, knowing how they might react to the toxicity of local anesthetics by their liver health, by their body size, by their history of local anesthetics being injected to them in the past. For smaller patients, make sure you calculate the volume of local anesthetic you plan to use. Know the milligram per kilogram maximum dosages allowed for your patients, and weigh your patient and then calculate the maximum amount before you start. Never go beyond. Be familiar with what the signs and symptoms of local anesthetic toxicity are and local anesthetic allergy. Know when to give epinephrine, know when to give Benadryl, know when sedation is a sign of local anesthetic toxicity. And be practiced. Make sure that you and your office team are practiced in how to manage all medical emergencies so that you are more proficient when they occur. So, before I answer some questions that people may type in, I'd like to once again thank Puro Pharma for sponsoring this talk. Again, they are a local anesthetic manufacturing company internationally. I'd like to thank Viva Learning for getting the portal, making it available for us to share information. And I'd like to thank you all for taking past hour or so to listen. My contact information is on the first slide. You're more than welcome to send me emails if you have questions. I know there's a lot of you. There's something like 1,100 or 1,200 people listening. But if you have a couple questions, go ahead and I'll try to answer them if people type some questions in. Thank you all, and have a nice day, evening, morning, afternoon, depending on where you are. All right, question. Sorry, 1 sec as I click on the question boxes. Is there any association between the amount of caffeine intake and local anesthetic efficacy? The only thing that I would consider to be at all relevant is that caffeine, a lot of caffeine intake may increase the blood flow because it causes the heart rate to increase. And theoretically, that could wash away local anesthetic faster, but that would have to be a whole lot of caffeine and not very much local anesthetic. So I would say probably not. What is the patient weight below? What is the patient weight that is below the maximum dose? At what weight we need to... Sorry, I don't understand that one. Let me click on next question. Someone said, thank you, you're welcome. Yeah, I don't see any other questions. So yeah, I guess that's it. Oh wait, sorry, hold on. I see a question box. 1 sec. Nope, that's it. So that's it. Thank you very much, and have a nice day.